So, I mean, you probably witnessed sort of already a little bit of conversation I had with Mark whilst I was waiting to get the go-ahead.
Oh dear.
So, welcome to everybody to our first academic afternoon in 2021. And I would like to, before I introduce the topic and our first speaker, just say a few words about the choice, the particular choice of this topic, because it may have raised a few eyebrows. Yes, of course, we are in the midst of the COVID pandemic. Actually, as some people say, as far as the second wave is concerned, in the eye of the storm. And when we decided to choose this topic, moving beyond COVID-19, what are the implications for us as psychiatrists? We actually didn't even know at the time as to when the vaccination is going to come about, and is there a way out soon, really, out of this very difficult period. But we did decide to do so because it felt that hope is really the one thing that we all rely on as we look towards the future. And also, there was some kind of an observation that lots of colleagues shared with me during the period, and that was the kind of realization that the parity of esteem notion that we spoke about for many years was suddenly turning into a bit of a well, beast in some ways, really, because it was no longer a notion of, well, this is what we have to do as psychiatrists, reminding ourselves that we are doctors in the first place, but it's the harsh reality of what we all faced and still facing right now. I mean, I just came out of a London consultants meeting where we together dedicated our thoughts to colleagues we lost very recently. Not only we lost a trainee doctor last year, we lost two consultants very recently. So I think all of that forces us to essentially have a careful taking stock exercise of what's our identity as psychiatrists, what is the focus of what we are doing as we go forward in terms of reinterpreting our identity. And I guess it comes from various perspectives. Not only are we going to deal with a number of new conditions as doctors. I mean, long COVID is just one condition that seems to represent the biopsychosocial of what we are dealing with in significant numbers. We will most likely see a tsunami of patients with anxiety, depressive disorders, PTSD, somatoform disorders coming to services in the months to come. So taking all of that together, I hope that you don't regard it as inappropriate to talk about the beyond COVID perspective, but to, together with the two experts that we have today, just share reflections and start to think about what does it mean, not only for here and now, but for the future. So today we're going to hear from two very competent and experienced colleagues about their reflections about the impact of COVID for the future of our psychiatrists. And I'm very grateful to Kate and Mark that they accepted the invitation, despite the fact that obviously everybody's dealing with a number of very challenging issues right now. And I just had permission from Mark to disclose that he's actually going through his COVID infection right now. So he's in his 8th day of battling with COVID, and checked it on a number of occasions, and he gave me his reassurance. No, it's okay. It's right to talk, and this is my way of coping, I suppose, to a certain extent as well. So here we are, and so it's my great pleasure to introduce Mark Salter to you. Those of you who don't know him, he's a general psychiatrist in East London. He's also known to be a filmmaker and writer. And I've known Mark for more than 20 years. And I have to say that his perspective towards psychiatry has always been, for me, a rich source of inspiration, because his creative mind always allows him to think outside the box, look towards the future, but also refer to rather difficult personal experiences in the way he kind of reconceptualized his own identity as being a psychiatrist many, many times. In 2008, Mark published a book together with his colleague Trevor Turner, another psychiatrist who always pushed us in the way he kind of represented psychiatry to rethink, I suppose. And the title of the book is Community Mental Health Care, a Practical Guide to Outdoor Psychiatry. And even in that book, the last chapter is called The Challenges of the Future. So you can see that this is a repetitive theme in Mark's thinking. He contributed to big debates in psychiatry across the various platforms, and I highly recommend his YouTube talk, Psychiatry and the Meaning of Pain. And of course, nobody can introduce him any better than Mark himself. So I would like to quote two answers he gave to questions in an interview published in the Psychiatry Bulletin in 2008. So the first question was, what has been the greatest impact of your profession on you personally? Mark's answer was, it has made me realize just how far we still have to go to before we can begin to use our knowledge of mental life to make the world a better place. And the second question was, what is the most promising opportunity facing the profession? And his answer was the growing realization that a workable synthesis of biological, psychological, and social knowledge is no longer clinically irrelevant. And I think that very nicely sets the scene, Mark, for the topic of today. So I would like to invite you to give us your talk.
Thank you very much for that extremely thoughtful introduction. And I intend to do exactly what I said on the tin, and especially those last two quotes. And I'm going to set out, I think, the reasons why I think I can now justify the need for that all-important biopsychosocial synthesis. Note the 6 syllables there. Never use a phrase that's got more than 5 syllables in any one word. Anyway, I want to tell you a story, first of all, about a patient, a COVID patient, or a COVID story, perhaps. Oh, I need to share screen, don't I? Please forgive me. Where are we? Sharing screen. There we go. Hopefully you should have that on your screen, and we'll go on to the talk. Can anyone see that? Maybe I'm just making sure. I'm just going straight onto it. I'm not getting the. I mean, if you could intervene, perhaps. I'm not getting my user view. I'm sorry about that, everybody. Rather embarrassing introduction there. Yeah, I want to start with a case, really. Not long in the COVID pandemic, I was asked to speak by video link, as it was, a Zoom, with a 33-year-old drug dealer who'd just been released from prison. As you well know, quite a few individuals were released from prison because of the need to get people out of COVID-infested prisons and back into their homes. He was just, a lad from Hackney. He'd done his usual. He dropped out of school and socialised with the wrong sort, and had done rather well for himself. And he'd done 2 spells in jail, sufficiently up the pecking order of the top boy ladder to only spent 2 times in prison. And he was out for the 3rd time, deciding he was going to go straight. But he was indoors, and he was hemmed in by the virus, and he was bloody miserable. And he was starting to have bad dreams, and went to his GP with the dreams, which were biographically relevant, and said to the GP, I need help with this. When he came to me, the GP had asked me for diagnosis and management advice on possible PTSD. The young lad complained of vivid, terrifying, intrusive recollections of a sound at night that kept him awake. It was the scream of the man into whom he had thrown acid some years ago in one of his routine day-to-day drug jobs. And here he was now, some years later, and saying to me on the screen, why is this coming back to me now? He'd done this 3 years ago, but it hadn't really occurred to him that this idea was sort of storming into his mind until very, very, very recently. That raises to me a very interesting lesson from COVID. Here's this guy locked at home, and what is he doing? He's reliving a memory that somehow he's managed not to think about because he just got on with his job. I'll put it another way, this guy is teaching us that what we do all day, otherwise known as live life, is an adaptive coping strategy. And some of us live better than others. And when stripped of our usual domestic routines, this guy was frightened to go out into the street with his knife and do his business. He's had an awful lot of time to think about things that he's spent a lot of time staying busy by not thinking about. Why is this coming back to me now, he said. Doc, I want a diagnosis and I want treatment. What this guy was looking for was an answer. And what I want to do today is say, well, what exactly is it we can do to offer this chap or to any of our patients? And what's COVID taught us about this? See, this guy's asking for a simple solution, but as I was sitting there on the screen, and I'm sure all of you have been through this in your own experiences in the last few months and the last year, I couldn't reach out to him in the way that I wanted to. He wasn't in the room with me. There was something about the screen with its limited bandwidth and the lack of the clicking and the whooshing and the sound of his breath and his face and the God knows what microscopic details that I was taking in from this man's face that I would have taken in effortlessly in a clinical room, that I could no longer have available to me in the same way. This was a muted version of him. Now look, psychiatry has got no fancy gadgets, we know that. It's got two gadgets. It's got the mind of the person, it's got the ears of the person, and language. But most importantly, we are reliant upon our clinical information in front of us to do what we can. COVID is dampening that. And already we're hearing talk of virtual clinics in the future as the way forward that strip us free from that precious wealth of information that is the fundamental bedrock of what we do for a living. And that's what I want to do today. I want to talk about what that bedrock looks like, where it comes from. My answer is it comes from the evolution of the brain. And I want to talk about some people who have said some very interesting things about the way in which we can make use of that information, that vast, complex, interpersonal richness of data exchanged between us, unthinkingly, automatically, every time we open our eyes or look or listen or smell someone. So I'll come back to that in a sec. I want to go back first of all, though, to around 1808, and the person that coined the term psychiatry in the first place, the great German psychiatrist Johann Ryle. Now, Ryle isn't quite as well known, other perhaps for coining the term psychiatry, than perhaps, say, Kraepelin or Husserl or Jaspers or the two Schneiders, of course, pioneers of psychopathology. But Ryle was particularly interesting man because of the way he wrote and when he wrote. Earlier on than most of his great German colleagues, he coined the term psychiatry in 1808, but his point was that there was no metaphysical aspect to madness or mental illness. The mind and all the things that go wrong within it, i.e. mental illness, is a disturbance of a relationship between the organ, the mind, and its connection to the world. Now, he realized that the world's a pretty damn complicated place, and that's something that he saw pose a serious problem for complexity. And complexity is a word I will be returning to quite a lot in the next 25, 30 minutes or so. Another interesting thing that Ryle said, and I think we need to have this as one of our cornerstones of our way we speak to people out of profession, Ryle said, it's not a branch of medicine. We somehow see ourselves, sometimes apologetically, on a par with physicians and neurologists and so on. We're not. Anthony Clare put it far more wittily than I ever could, but he simply said that psychiatry is the other half of medicine. That was also quoted by Strauss in the BMJ in 1933. But the idea that psychiatry is a cornerstone of medicine, and for Ryle, the other two were physician, general medicine and surgery. His idea was that psychiatry was a fundamental bedrock of medicine. It's not a specialism. It's not a branch of medicine. It's not. If anything, it's the trunk. And by some accounts, looking at our recruitment rates, it's a somewhat withered and battered trunk. Now, we'll come back to psychiatric recruitment in a minute. Ryle also was wary of the fact that we must be very, very careful to see psychiatry in its practice independently of the prevailing social mores of the age. Witness, for example, psychiatry in Nazi Germany in 1933, or British psychiatry with lobotomy in 1955. The moral values and the way we treat mental illness is a crucial thing. And another point he made, and I think this is something we need to say far more clearly than we do, only the best doctors should practice psychiatry. And this is where we come to the word complexity again. Now, let me just give you a quick tour of what I think are the interesting facts about our profession. Here we are, a quick history of our career spelt out in 15, 16 headings. Don't worry, I'm not going to go through all of them now, but I want you to look at one or two variable aspects of this particular list. Notice that in the beginning, our constructions of mental illness were pretty simple. It was punishment from God. We had a metaphysical, fundamental understanding. So the first understanding of madness, in a way, or mental illness could be seen as a metaphysical explanation. But look how we progressed over this time through to the present day. God has slowly given way, and other ideas, and the metaphysical ideas, the spiritual ideas, if you like, to a much more physical progression. There's a trend in this graph as we go down from the metaphysical to the physical. Another thing, too, is to look at the fact that there is a trend in complexity. I think it's fair to say that life was probably simpler for the Buddha and the people living the lives of the Indian Vedas, or who are described in the Vedas, or indeed any other person perhaps in the first 2 millennia BC, compared to the bewildering, cognitively loaded world in which we now practice and work. But please don't think that this progression to complexity is in any way a linear progress down this graph. For a start, notice how the Buddha, who was banging around in 300 BC, his Dhammapada gives a precise description of cognitive behavioral therapy with an acceptance component. Buddha set the whole idea of mental illness inside the mind in a godless universe that was infinite, and set out a precise description of cognitive behavioral therapy with an acceptance component that Aaron Beck would be proud of. That's quite a thing. So the idea that we haven't had extremely profound and sophisticated notions of psychiatry from way back when really actually is a myth. But the progression to complexity we've seen more recently has taken us, I think, in a different direction. Now, we could go through this at great length, but I think perhaps one of those fundamental turning points for Western civilization is the Enlightenment, bringing with it, of course, this phenomenal scientific resolution that transformed the way that we think about the world. It transformed the whole face of human civilization. From politics to poetry, there wasn't a single bit of the Enlightenment, of human life that wasn't, as it were, influenced by the Enlightenment in some way. With one exception, and that was the strange business of the mind. And you may remember the famous French psychiatrist, René Descartes, who came up with that famous misquote of all times, "I think, therefore I am." He was a person who decided that by a dodgy bit of autophenomenology, he could prove beyond doubt that he had a mind because he was thinking, and thereby sowed a very poisonous seed for the future of psychiatry by saying that rational mind was the sine qua non of being alive and human. And whereas he was quite careful to, he was an anatomist, but was quite careful not to locate the specific locus of this magical thinking thing, as he called it, the res cogitans, anywhere in the body. Anatomist that he was, he didn't dare, plus because he was a Christian, say to the church, this is where the mind lives. He still had to honour the soul. And so he ducked that one and admitted in a sense that the res cogitans, this thinking thing, was somehow a magical, ethereal spirit. Meanwhile, Harvey went on to discover circulation. Darwin went on to describe evolution. Charcot and Freud went on to hypothesize the unconscious, and many, many others. We had revolutions in physics and politics, the French Revolution and so on. But what has really happened is that the mind never caught up. We simply didn't have the information available back then in the time of Descartes. And a split between the unbelievable mind-numbing spiritual metaphysical complexity of the mind and the incredible wealth of information we've generated about the body ever since has led to a steadily widening gap between a privileged metaphysical special notion that is hors de combat of science and the bodily, which is easily given over. A chasm began to widen, and as it widened and widened and widened, psychiatry as a specialism drifted away from the rest of us. The mind-body split of the Enlightenment is alive and well today in a metaphysical way that I'll hope to demonstrate. And it is the reason for psychiatry's dire recruitment problem. I want to whiz through this a little more quickly now because I've got plenty of other things to talk about. But notice how we've had a pretty up and down sort of roller coaster, the reputation of our profession. You know, Freud came up with some interesting ideas that are pretty wacky. Lobotomy was not our finest moment. Drugs that worked did. I want to mention Alan Turing as well a little later, but I'll come back to him in a sec. But notice how deoxyribonucleic acid laid the foundation for some fundamental understanding of our profession and how we can work today. Deinstitutionalization, of course, was famous, but I want to come on to the other things, the rise of risk and managerialism, in a few moments. The last thing I want you to look about this graph, this line, this list, however, is to consider, where is the power here? Notice how psychiatry and the way we work with the mentally ill varies depending upon the extent to which at any one of that period in our history, that particular civilization values individual autonomy. Or putting it another way, you can judge a civilization by the way it chooses its psychiatrists. The more we value individualism and the right to have a mind, the more sophisticated our ideas. Now, sophistication is one thing, certainty is another. Bertrand Russell, the philosopher, made a very interesting point that what men want is knowledge, not knowledge, but certainty. Need certainty. I'd like to suggest today, if you're thinking that the need for information is an appetite like any other, it's just as important to us as oxygen or water or food. I would like to think information as biologically indispensable for the same reason that my drug dealer was, I couldn't reach his information because of Zoom and COVID. All these things were getting in the way. But look, let's get right back to the beginning of time. We do know that from the very, very beginning, when life was first evolving on this planet, it had to negotiate its way through the theoretically infinite complexity of the world by steering towards food, away from predators and away from toxins. In other words, information is crucial to us for survival. And if we can maintain constancy in the living organism, which is best understood at its simplest level as the homeostatic function of the individual living cell, then by maintaining constancy, or perhaps in certainty, we have got a base upon which to evolve. And this is pretty much what we can say has happened. We can see life, in a sense, as having retained that same biological constancy in our genome. We share 50% of it with a banana. The homeostatic cytoplasm cell regulation at the intracellular level is the same in virtually every living thing on this planet. And that same constancy goes all the way from there to human civilization, or birds building nests, or humans building sentences. We can see the biological need for certainty is fundamental. Now, those ideas were not available to Descartes and his types and any of the great Enlightenment theoreticians. Look what's happened since. Bridges, thanks to science, have begun to appear across the mind-body chasm. We no longer need to rely upon a metaphysical explanation of mind, the res cogitans. And look what we've come through. Darwin, in 18 whatever it was, came up with the evolution of the theory, the origin of the species. And he came up with an astonishing idea, what Daniel Dennett has called Darwin's dangerous idea, the blind evolution of intelligence. That is to say that intelligence arises out of nothing, out of just dumb animal matter. Around that time, there are many other contemporaries working. Freud was working, and Hewlin Jackson was the first person, a great British neurologist, in fact, of our local hospital, to observe that the central nervous system could be understood as an inhibitory hierarchy of forces, of influences, with the disinhibiting and the inhibiting functions of the frontal lobes of the nervous system. And we'll come back to the frontal lobes later. Meanwhile, Durkheim was taking those same elements of scientific empiricism and applying them to society, and came up with some robust, predictable evaluations of mood, suicide, and social behavior. Intriguingly, Sigmund Freud, in one of his better books, identified a clear correlation between Jacksonian ideas of inhibition and the superego, and posited, in those humbling days, a possible explanation for the way that civilization might, in a way, mirror the mind. Only a few years later, after Freud had published Civilization and Its Discontent, one of his last books, Alan Turing published a truly remarkable observation on the role of information in the generation of intelligence. He posited the idea of an algorithm that could generate seemingly intelligent action from dumb matter. Darwin provides the intelligence, and that intelligence can be based in dumb, hard molecules. And only some years later, as you may recall from my previous slide, Watson and Crick found the as it were, the substrate for that condition, DNA. So we've got now an idea of intelligence emerging out of the blue, but only the psychological revolutions of the last 20 to 30 years and the neurological revolution have come up with even greater, clearer ideas. Daniel Kahneman's masterpiece, Thinking Fast and Slow, is a cataloguing of the flaws and the strengths of the two parts of the brain. The old, fast brain, that same brain that has evolved over millions of years to keep us alive, to keep us swimming through the uncertain world by generating images of just enough certainty to stay alive, to reproduce, to go on and evolve. Now, we can do that remarkably quickly. When you and I sit down with a patient in a real world or via Zoom, we are taking in vast amounts of information, and that fast brain, is extremely intuitive. The fast brain, which is 1.4 billion years in the making, is capable of doing way more than the slow brain, our so-called thinking brain, ever could. And it does so by using shortcuts, heuristics, to make judgments under rapidly changing, uncertain situations. That is what we need to use in psychiatry, understand as central to the way we practice. The heuristics of substitution, of course, make sure that it's biased. We don't come up with the correct answer, we come up with the answer that will keep us alive. Kahneman posed the famous problem. Take a bat and ball set. The bat costs $1 more than the ball, and the entire set costs $1.10. The difference between the bat and the ball is $1. What's the price of each individual item? I'll say that again. A bat and a ball set, $1.10. The ball is $1 cheaper than the bat. What's the price of both items? If you think about it, just for a few secs, how many of you have come up with the idea that it's $1.10? The fact of the matter is that when you are confronted by a matter in real time and under pressure, cognitive load, you will leap to answer a substitute question. When confronted by a complex question, how does the mind work, the price of a bowl and a bat, we answer a simpler question instead. Instead of using our slow brain, our thinking brain, which is lazy, we fall back under pressure on a much simpler construction of the universe. In other words, our brains are dumbing down because we've had 1.4 billion years of evolution that tells us that it works. Now, Kahneman was a psychologist. He made no reference to anatomy, but the more recent work by Antonio Damasio, the neuroscientist, in a superb book, The Feeling That Comes to Mind, talks about a very interesting observation. He notes that consciousness in all its forms is best understood as occurring at the fundamental cellular level of the brainstem. For him, the brainstem means all the way from the medulla oblongata up to the pons. And in that situation of homeostatically regulated neuronal stability is the proto-self, onto which incoming sense data from both the memory, the soma, and the external sensory apparatus stimulates and triggers perturbations and waves of activity that stimulate what we call the core self. The core self pretty much substitutes or stands in for Kahneman's fast brain. Most of that does the thinking. And some of the cognitive studies that he publishes in his book demonstrate the phenomenal clarity and the intuition and the imagination and the sharpness of judgments in this ancient brain of ours, which we dismiss at our will. He also notes that sitting on top of that, and this gene has probably only been a mutation of about maybe 100,000 years, is Kahneman's slow brain, the clever one. This vast amount of information that's available to us has to squeeze through a bottleneck to get through the thalamus and into the cortex, where it extracts information made available to it from the ancient brain and strips it of all its real-world connections. The slow brain has capacity, working memory, of 5 plus or minus 2 units. And when an item of information is taken out of the richness of the complexity honed over those millennia and into the new brain, it is abstracted out of recognition. It becomes symbolized, and the symbol, E equals mc squared, for example, would stand in for the word. In other words, when we put something into our thinking, in our conscious thinking brain, we strip it of all its real-world context. Now, that's very, very well if we can use that brain to use E equals mc squared, for example, to inform us of where we're heading and feed that back to the old brain to enrich its data and in a wonderfully circular way, enrich the entire pool to generate, well, pretty much the discoveries that the Enlightenment is generating. The tension between the new and the old brain, however, is a difficult one because only a certain amount of information from the old brain can get through to the new. We're under cognitive load, as Kahneman reminds us, the new brain is lazy and switches off. This is quite important because it tells us that if we can take a neuroanatomical understanding of the brain and apply it to psychology and its connections to the world and its connections to the structure of the brain and our history and our relationship to ourself, then we've really come a long way since the wacko, metaphysical, magical thing of res cogitans that Darwin suggested. And I would say to you that res cogitans is alive and well. The stigma of psychiatric disorder and the number of times that you as psychiatrists have been told, well, you're sitting at a dinner table and someone said, what you do for a living? And you tell them what you do for a living and they say, oh, I'm so sorry to hear that. That must be so difficult. That's res cogitans, that's magic, that's prejudice, that's primeval fear speaking. And it's generated a series of interesting myths, one of which is that the human mind is a sociobiologically indispensable illusion. You see, we tend to think of the brain as all important, but it's not. The rational brain is just that, an illusion that we need to stay alive. And most importantly, the mind is fundamentally embodied in its relationship to the world. And there aren't many branches of medicine or science that spend their time talking to sick people who can look after or understand this idea. Psychiatry is uniquely positioned to do this, way better than pathologists or neurologists or orthopedic surgeons. It's also a curse and a blessing to our profession. You see, my argument is that complexity is switching off our ability to think about the world in anything other than simple, dumbed down, abstract terms. What's the simplest out of the biological, psychological, and the social? Answer, the biological. Good old-fashioned hard molecules. Hey, switch off the brain, cognitive load. Let's go for something very, very simple. That's why it's impossible to get decent research done on psychosocial studies. And that's why it's so easy to get a grant funded. You get grant funding for a biological or a brain scanning study. The brain is hardwired to prefer and talk about biological, dumbed down, stupid versions of itself. Now, that sounds like a rather strange thing. Let's just go through some of those ideas. Diagnosis is a psychiatric turkey, let's face it. It promises far more than it can actually deliver. But let's think about what diagnosis does do, first of all. It should reassure the sufferer that someone out there understands. And of course, it can be a rallying point for service users, including the very angry myalgic encephalomyelitis association or the anti-psychiatry movement. It can be very helpful as intraprofessional shorthand. You know, have you seen that, that borderline in bed 7 that came in last night? We can, in varying degrees, use psychiatry and psychiatric diagnosis in useful ways. But as shorthand, that's useful, but we have to be careful not to over-offer what we can actually do with it. Because the fact of the matter is that in many, many ways, psychiatric diagnosis simply does not correlate with real-world complexity. Notice how many studies of drug styles, schizophrenia particularly, exclude patients with comorbidity of personality disorder or comorbidity of substance misuse because we want pure schizophrenia in our study. As if somehow that's any purer than we're running away from the complexity there. We use diagnoses to guide research, but the fact of the matter is that our diagnostic categories are constellations. They don't necessarily actually stand in or represent a real thing. Think about when we think about depression. I'll come to that in a sec. The real use of diagnosis is not for us. It's for the managerial culture that now has power in this world. Earlier on, I told you that Ryle warned us to pay attention to the prevailing cultural mores of us as any civilization. Our civilization values power, and that power right now is in the hands of the executive, the managers, and the system. Or as Michael Gove put it, I think we've had enough of experts. Doctors are being reduced from professionals to tradesmen. And the real benefits of diagnosis, in my opinion, are to give, as it were, equity and self-expression rights to autonomous individuals, but also insurance, entitlement, payroll, service decommissioning. Think about how many of our services now are structured by the way the service is centered on diagnosis. Equip, for example. And just look at the way we categorize them. Diagnostic categories say more about the categorizer than the categorized. Notice how we've had this astonishing profusion of categories in our famous text, of which I'll take the DSM 1 to 5 as perhaps the most spectacular. Notice how homosexuality was an illness until 1974. Homosexuality, hey, that diagnosis killed Alan Turing. Hey, what we've done was invent the computer, actually give up a fundamental model of the openness and the complexity of the universe, and we're take us halfway towards winning World War II while we were at it. But no, that man was forced into chemical castration and took his life under those circumstances thanks to a psychiatric glitch. Homosexuality equals illness. By then, Freud was running rampant through our classification so that everything looked like an illness of one form or another. And it was DSM-3 that tried to bring certainty, operational certainty, back to our understanding of this bewildering, confusing miasma of definitions in 1980 by introducing categories such as PTSD. Just the revised version, DSM-4, with its multi-axial, the biopsychosocial axes, was still doing a pretty good job. And then DSM-5 comes along, and what happens? You medicalize grief, and it abandons the biopsychosocial axes of the 5-axis system on the grounds, and check out the APA writing on this, it wasn't scientific enough. Henry Maudsley saw all this coming. In his book, The Physiology and Pathology of the Mind, he said in 1867, we have a sufficiently strong propensity not only to make divisions in knowledge where there are none in nature, and then to impose these divisions on nature, making reality conformable to the idea, but to go further, to convert our generalizations from observation into real entities, permitting for the future these artificial creations to tyrannize our understanding. Depression is the second commonest illness on the planet, says the WHO. That is a tyranny of our understanding. Depression is a domain, not an illness. I'll give you proof of that in a sec. Nancy Andreasen very pithily summed up Henry Maudsley. More simply, we have sacrificed validity for reliability. Hey, it's reliable. Who cares if it means anything? This is where psychiatry is heading. And medical students are noticing this at very close quarters. I don't think they're impressed, to be totally honest. Look at research. Some years ago, I spoke to Sir David Goldberg for a podcast for the college, and he said to me that, he thinks depression is a good, valid starting point for inquiring into abnormalities of mood, appetite, belief, and so on and so on and so on. The truth of the matter, of course, as Gordon Parker said in a very readable editorial in the Yellow Journal 2 years ago, depression is a domain, not an illness. And if Robert Kendall, one of the greatest professors we've ever had as chair of our college, could not classify depression as a genuine entity, no one can. But when you put something like depression into the brain, the new brain, the thinking fast brain, the thinking brain, we strip it of all its real-world complexity. Every time we use the word depression, or even worse, a depression-related myth like serotonergic imbalance is the cause of depression, we are actually doing our patients and the world a disservice. Our diagnoses are no more than constellations were to the ancient Greeks, points of light in the distance, each of them clinically valid observations, but the shapes they make got nothing to do with hunters in the night sky or fairies. They're just shapes that are an illusory pattern. Now, some of those illusions seem to be more valid than others. Mania, for example, is a good syndrome, but I don't know. We need instead, and Joseph Ledoux, the American science writer, puts this brilliantly, we need to drill down to much more specific elements of clinical psychopathology to look at clinical validity. So, for example, the biological markers of hypervigilance after trauma. Look at that and check that across big data brain scans of various tissues of the brain. Don't just look at the operational criteria at DSM, but drill down to the real thing. We do that, maybe we'll get somewhere. I'll come back to that a bit later, perhaps. I mentioned earlier on that managerialism has taken a lot of power. Well, read A Question of Trust by Honora O'Neill, the BBC Reith Lectures in 2002, and you'll see an eloquent discussion of how that power has become socialised away from professionals. The centralisation of authority allows control in an increasingly complex world where it could go bottom up at any moment, as we've seen very spectacularly on our screens in recent days. And look how we can use something, cognitive load, to justify a nervous frightening back into our ancient quick solution brain. It's very fair to say that Harold Shipman and Christopher Clunis did more to change psychiatry, or medicine indeed, than any president of the Royal College of General Practitioners or Royal College of Psychiatrists. Risk was ushered in, and we were now, thanks to the Smith report, subject to revalidation once every 4 or 5 years, propelled fundamentally by the assumption that, it could happen again, and by implication that there might be another serial killer lurking out there in the medically qualified. Similarly, the way in which we decided to revalidate the suffering of the young doctor, to reduce the many hours of work, all of which, of course, were feeding into this vast, rich store of the unconscious brain, the intuitive, imaginative, knowing brain that interacts sublimely with our patients, and replaced it with the European Waiting Time Directive and the Monotonising Medical Careers Initiative, both of which saw to the death of the firm. And look at our services now. I mentioned services just now. The waiting list for psychotherapy in my trust is now over a year. And when you get to the end of that waiting list, you'll get to a group. You're lucky if you get individual therapy. That's awful. That's a running away from the complexity of the psychosocial, if ever there was one. Equip. Well, if there's substance misuse involved, sorry, over 30, no, can't come to us. Early intervention psychosis. Anyone here remember assertive outreach teams? RIP, assertive outreach. The fact of the matter is that these clinics and their arrangements are not there for the patient. They are there as an organisational defence to manage the uncertainty of the system. Your outpatient clinic for your SHO is a storage silo. The depot clinic, patient comes in, how are you? It's a syringe. Quick questions. If they're lucky, you'll get a negative symptom checklist. They'll be asked how they are. No one's going to ask them, what have you been doing all day? Like I was trying to ask my drug dealer. The storage silo basically is the function of the inpatient unit. It was always the role of the asylum. It is not there to treat mentally ill people primarily. It is there to contain our uncertainty about complexity. Much easier to give it a depot than do anything about understanding it. That is the clumsy, dumbed down brain speaking, and a frozen brain that should be thinking more deeply about the need to embrace everything, biological, psychological, and social, as the fundamental starting point for the way we practice. But no, we're still putting on, as Frank said just now, about parity of esteem and trying to get funding for biopsychosocial studies. Look at Sushma Gupta's editorial in the Yellow Journal 3 years ago. Is there still a need for biopsychosocial psychiatry? And let me start it on the split between the ward and the community, another fragmentation of silos, or even the shrinking discharge summary. So what on earth can we do about that? Well, first of all, I think we're going to be much more honest with the public. I think we need to, stop dumbing down and be honest and say that diagnosis is a bean feast for whoever wants to use the diagnosis or whatever their interest is. But for psychiatry, it should never offer more than we can honestly answer. We should ask about it and deliver more than we can provide. And because the mental state is in the life of the person, and that mental state has been constantly changing since they were born, we should always be looking for the mental state in the history and the history in the mental state. Was there a predisposition towards hypervigilance, not trauma or intrusive recollections, but hypervigilance in that person before they actually had the road crash? Is there a correlation between their childhood experience of child sexual abuse and hypervigilance? Is there a connection between that and a subgroup of people for whom we have done MRI or PET scanning of the amygdala, the lateral nucleus of the amygdala, that predicts hypervigilance in clinical populations with that same brain scan going on to develop the illness in longitudinal studies? We can use these ideas to actually inform the mental state and the history of each other. And we should always ask every time a patient comes to us, why now? What was your best level of function? Why is your illness now getting in the way of your hopes and dreams for the future? What has been the rate and the nature of your decline? What are you stopping from doing that you used to do all day? What are the body symptoms? What are your relationships? Now, of course, these things all sound like taking a proper history. We don't. Why not? We haven't got time, haven't got the funding, haven't got the services. I've got 5 more patients to see. We somehow seem to see that as acceptable. The idea that politics, time, pressure, funding, social work, and God knows what else are relevant is to know that they're seen as hors de combat. They're seen as though housing and social problems and poverty and despair. It's down to be like Peter Burns who write editorials in the Bulletin saying, for God's sake, we have to take inequality seriously. That shouldn't have to happen. These things should all be being embraced by all of us. And if it can't, it is the job of psychiatrists to do something about speaking this out far more loudly than we do. Demand full presentations on every ward round. And if that ward round goes on to 4 in the evening, so what? That's what we have to do. Doesn't sound very comfortable for those brought up on a diet of European waiting time directive, perhaps, but that's what we have to do if we as psychiatrists are going to do what we need to do and stand up with our skills and take the status and the head of the role of leaders in this situation. And the best way to do that is by bringing everyone on board. Every ward round, every clinic, always ask a relative, always ask the nurse, the student, and of course the patient for their points of view on what's going on. Now, we always say in discussion, that's all very well for a psychotic person. Doesn't matter. Don't get focused on, bogged down on the difficulties of one particular person. My suggestion is that we connect with the wider world. We should teach far more all the time, whatever, whenever, wherever. It could be a gentleman's urinal, it might be a dinner party, it might be a grand round of Barts. Doesn't matter. We have to talk about the biological, the psychological, the social all the time. And for God's sake, we have to drop the biopsychosocial model. Call it the tripolar model. Anything that's sensitive with shorter number of syllables is going to be easy to listen to. And remember, reducing the cognitive load, we can handle it. We will remember it more. We will take it in. We can shape our language to our listeners. We should be very, very careful about the way that we communicate and write. We need a serious expansion to the intelligence of the public communications unit at the Royal College of Psychiatrists, because the brain is the only organ in the body that can vote. Slogans can be very powerful in the right place, as young Donald has told us. 20th century funding for 21st century problems, this is a serious problem. And because of the cognitive load we're under, we are dumbing down. We are suffering from an organizational dementia, which is managed managerially primarily and not clinically. Ever hear of a journal called Evidence-Based Management? Why not? We need to spread these ideas, these passively seditious ideas that we've come so far beyond res cogitans and magical thinking stuff into a hard model. Turing's ideas, Darwin's ideas, philosophical ideas, biological ideas, and we can generate these things into a meaningful, unbelievably complicated, but meaningful, valid understanding of how the mind works. And the most important bit of the mind is not the thinking bit that we think it is, the rational bit of free will, the bit we section when it goes wrong. It's the bit inside, the feeling, the touching, the reaching out, the embracing the complexity of the other person. If you like, every single thing that the old brain does automatically. Check out Antonio de Matteo, page 250, and the research of Dijksterhuis on intuitive decisions in difficult situations and their efficacy compared to fast responses. Intuitive fast responses by Dijksterhuis in comparison to the efficacy of intellectually deliberative choices and decision making. Bottom line is, evolution's cleverer than we are. And we need to get the old brain and its infinitely rich connection to the human world and the world outside with all its uncertainty and complexity back at the heart of what we do. We can teach these things through supervision. Supervision after looking after patients is the second most important thing we do. Hippocrates said that 2,000 years ago. The Royal College president at the moment has said that courage is the most important ingredient. We have to basically take things further forward and demand time and resources. And if not, you're going to get the psychiatry you deserve. After all, you can judge a civilization, as I said, by the way it chooses its psychiatrists. You have to be brave and be honest. And that's going to mean people being uncomfortable. And in this comfort-crazy world of ours, with enough discomfort coming in the future, we're going to have to find clever ways to do this. And hopefully, this lecture is a chance to stimulate this. I'd like to end with one other interesting thought. Anthony Clare and Ryle were quite correct when they said that only the best brains should go into psychiatry. But given that monotonizing medical careers now dumbs down the way that we actually think, and thanks to the phobia of experts, it now passes for normal in our culture, maybe psychiatry should actually acknowledge that it's not a branch of medicine, but a separate trunk, and declare UDI from the rest. What if Royal College of Psychiatrists declared unilateral independence and decided to have its own recruitment process? And one of the rules was you have to do an FY3 year. Sod off somewhere. Go and smoke marijuana, research working in children's homes, or write papers on neuroanatomy. Doesn't matter what you do. Come back in 3 years of real-world living when you've supercharged that ancient part of your brain, plugged it into the new part of the brain in a way you're not so cognitively loaded by complexity. Real-world experience. Nancy Andreasen in 1977 defined schizophrenia as a fundamental disturbance of real-world knowledge. Maybe it's time for psychiatric UDI and coming back. This time as it were, should we say, a higher caste of doctor? That's a dodgy word, isn't it? So, take-home message. There you go, in Zuckerberg red at the very top. These are the things I'd like you to think about. We are hardwired for certainty, not wisdom. We are dumbed down under cognitive load. And as the progression of science has seen over the last 2,000 years, our cognitive load is heavier today than ever before. That is the reason for psychiatrist recruitment problem and the tedium of the biologism into which we are now moving with our services, our organisation, our research, and the way we teach. Poverty and abuse can no longer be hors de combat. They are as fundamental as the genome, and they're as fundamental as anything we do every time we reach for an FP10. If we do this, we can turn complexity not from psychiatry's millstone, but psychiatry's touchstone. I'll finish there. Thank you.
Thank you very much, Mark. That was, again, a force of nature type of presentation, as I said last time when you spoke. I have to say that perspectives matter, don't they? Because
very much so.
Once I share your skepticism about virtual clinics and stuff, I mean, this time I've got you recorded. And also, it wouldn't have happened really today without our technical answers. So that is, yeah.
So, hey, Frank, I'm not for a minute saying we should drop our bows and arrows. You know, we can use them, but use them with intelligence.
Yes, yeah. So I promised you an inspiring talk outside the box, certainly comprehensive, critical, as well as uncomfortable at times. But you also always offer solutions. You don't get stuck in just naming the difficulties. And that was also the first comment in the box here, how interesting and inspiring, Dr. Salter. There was a comment about where to start. Do we need to insist we get sufficient time to assess patients in our teams? Would you like to say something about that?
Well, I don't. This might sound a bit crazy to actually, invoke the example of a 15-year-old Swedish girl with Asperger's, but I think we basically need to be more Thunbergian about our approach. I think we have to be very rude. I think we have to be honest. Sorry, not rude, please forgive me. I think we need to be challenging. We have to be imaginatively skillful at generating discomfort. Some of us are very good at it. I think one thing to do would go back to the writings and the broadcasts of Anthony Clare, The guy's a genius. I think we should really go back to Jasperian psychopathology. I think everyone should be forced to memorize fish psychopathology, which is basically, Allegominor psychopathology in English in about 30 to 60 pages.
Mm.
Returning to the precision of phenomenology, I think, is a very useful thing, because, that does not admit a diagnosis. There are so many things we can do. We should always ask, take a full history. And if the person doesn't have a full history of a ward round, come back when you have. We have to be really go back to some of the old ways, I think, of not throwing our weight around in a paternalistic sense, but I think we just need to up our game and say that, there's nothing wrong with gobsmacking complexity of psychosocial variables. We've got to embrace them. Big data can provide some solutions to that. I didn't have time. I was so mindful of the time, and in fact, I'm running a temperature that wasn't as focused as I might have been. But big data combined with with Jasperian psychopathology, phenomenology, could generate some very valuable things that would transcend the patterns that we currently think is reliable. For example, the constellation that forms depression. There are so many things we can do.
It's interesting you so highly push for the notion of psychopathology as a bread and butter of psychiatrists' phenomenological understanding. I have to say that it's challenging sometimes when you look at the curriculum, to see how we can reintroduce that and what place in the trainings where there is such a strong push towards modernizing psychiatry, the neuroscience of psychiatry.
Yep. Well, I don't know if you looked in Nature's Science Neurology a few months ago. A very interesting study looked at individuals who had experienced nervous hypervigilance, and they put them into a functional PET scanner, and they looked at the PET scan relationship between the lateral nucleus of the amygdala and its projection to the medial frontal cortex in hypervigilance anxiety. And they found a recognizable pattern in individuals who had all of whom had the diagnosis of PTSD. Then they started looking at large populations for that particular pattern in normal variants and took a history and found, surprise, surprise, that it predicted a history of previously undisclosed trauma.
Yeah.
That's at the level, and all they're looking for here is the clinical phenomenon of nervous hypervigilance, hypersensitivity to a specific cue that leads to autonomic overarousal and the switching off of all other behaviors to focus on the potential vigilant source of threat. That is something much narrower than the PTSD diagnosis. It's one fragment of one component of, criterion 3, I think it is, of DSM PTSD. Look at that at the level of the genome and of the connectome, as we say. I didn't have a chance to talk about mathematics, but Carl Friston, late of the London Medical School, has done some very interesting work on this. And his greatest hero, of course, was Alan Turing, RIP.
Right. We're a bit over time, but I would like to just relate to entries in the chat box here. Imogen is writing representation and inspiration. However, I'm stuck thinking we are powerless to change the system in which we work. This dismantled, fragmented service. I'm not sure how we can actually feasibly change the way we work on the system. Systems drain the curiosity out of us.
Well, I don't feel drained of curiosity, and I hope that I have injected a bit of curiosity back into some of the people listening. I think, you act as bravely as you think you are. And I think we have to be courageous. I think we have to say things again and again and again, which is that we have to be some very uncomfortable things, which is that our service is not designed to help sick people. We actually have to generate discomfort, as I say, is the answer to that. And we have to, some of us, well, that phrase goes, no good deed goes unpunished. Most people who dare to say things about the complexity of biopsychosocial integration, otherwise known as love and getting on with each other, tend to be shot or nailed to pieces of wood. We have to accept that may well happen to psychiatry. And here's another interesting thing. If when we do finally convince every single doctor on the planet that the biopsychosocial relevance is of importance to orthopedic surgeons just as much as it is to GPs, then we'll do ourselves out of a job. But there'll always be more complexity. So what we do, we come up with a good idea, we hand it to the neurologists, they're pretty dumb, and move on to the next lot. I'm saying is we can move deeper into the heart of the matter and make that our catchphrase. You would make it the college motto if we wanted to. But we have to use public relations and confrontative but gentle, skillful, witty ways of doing this. Simon Wesley was a master. Peter Byrne is a very, very talented wordsmith. There are so many people I know, we all know from our own personal practice, people who've got these skills to use language in this way that inspires and enlightens and opens up our eyes.
Right. I think that's a very nice final statement to just go into the break. Once again, Mark, really grateful that you pushed yourself to.
Sorry, a bit of a sweat out. So I'm just a little more focused sometimes.
No. and wish you just to get well really very, very soon. And we have you recorded, so we will actually spread the message. And
okay.
I will, let's take a 5-minute break, yeah? And then we will obviously go ahead with our second speaker, Dr. Kate Lovett. Thank you.
Thanks very much.
I think hopefully people returned from their short comfort break. We still have 229 participants in the room, which is great. And I would now like to introduce our second speaker, Dr. Kate Lovett, also general psychiatrist, clinically working in Plymouth, as far as I remember. That's still the case, yeah? And she's obviously very well known to all of us as the Dean, the County Dean of the Royal College of Psychiatrists until I think June this year, July?
That's correct.
Yeah. Okay. So Kate has campaigned strongly for many years for equality and diversity in general, and to celebrate the achievements of women psychiatrists in particular. I just came across a very interesting podcast recorded in 2018 from the, organized by the British Journal of Psychiatrists and the Mental Health Foundation with the title Women, Science, Medicine, Psychiatry, which features your views on systematic change requirements. I found this a very interesting perspective. But as with Mark, for the purpose of today's topic, I would like to introduce Kate with her own words, and I took this from a paper called 5 Minutes with Kate Lovett, BMJ 2017, where Kate talked about the findings of the review of psychiatric trainees' morale and training. Kate suggested that psychology should be a valid second science for medical students. And I quote from that paper, "Without doubt, a strong grasp of mathematics can also be a useful string to a doctor's bow, but we feel that the best doctors are rounded individuals with a sound understanding of both physical and mental health." So I think that is my kind of sort of setting the scene, Kate, for your talk of Psychiatry of Tomorrow, a post-COVID perspective. Over to you, Kate.
Fantastic. Thanks, Frank. So let me just share my screen with you. There we go. Can you all see that? Yeah, fantastic. So thank you so much for this invitation. It feels very poignant to be with you this afternoon. One of the first places I was invited to talk when I was elected Dean 5 years ago was at Barts and the East London Foundation Trust Education afternoon, and I shared a platform with Claire Gerarda and Debbie Cohen and Anya Corson talking about doctors' well-being, thinking about that together, and was so impressed at the cohesiveness amongst your psychiatry body and the care and support that you give to each other. And I'm very sorry that this is remotely today, that I'm not there with you in person. And I echo many of the things that Mark has talked about, and that connectedness and being together with people in the same room. We're having to think much harder to get the cues. And when I talk, I really enjoy talking and interacting with the audience, and it always feels very weird staring at a bright white light on the laptop rather than looking out into the audience. So thank you for the invitation. And I just wanted to add my condolences to all. I know that you have suffered really tragic losses of colleagues, and there will be many of you in the audience who are grieving the loss of colleagues and of family and friends. And I hope that the tone of this talk is right and takes that into account. It's very easy for us to become flippant about the absolute devastating situation that we all find ourselves in at the moment as a society. So the future. Talking about the future, it's one of those things that you can agree to talk about in the rush of dealing with emails and think it's a good idea at the time, and then sit down to write your talk and think about, well, what on earth have I agreed to talk about that for? I am certainly no expert on the future, but none of us are. So the future, a period of time that is to come, and key ingredients in thinking about that are things that we know about, knowns, things that we know that we don't know, and then the unknowns. And I guess the pandemic, to an extent, was on the horizon, was predicted by some experts around the world, but for many of us and many of our organisations, it's not been on the risk radar, and it was very much an unknown. So predicting the future, well, I'm absolutely no mystic Meg, and I can't claim to have any expertise. I don't have a crystal ball. But I have been involved in the past in thinking about training the psychiatrists of the future, and this was a paper that I was involved in co-authoring along with Melissa Arbuckle from Columbia and others, thinking about what do we need to skill the psychiatrist of the future to be able to do, how do we go about training them. And in preparing this talk, I thought it would be very interesting in retrospect to revisit what we were thinking at the time. So we talked about the wider world context in our paper, about societal changes that could be anticipated, changes in demographics, urbanization, particularly in the developing world, the impacts of migration, digitalization, cultural changes, and disasters, natural and man-made. And I can tell you that at no time when we were writing this did I ever anticipate that here we would be in the UK in the midst of a natural disaster and a global pandemic 3 years later. We talked about scientific changes, and Mark's already talked about the history of scientific development in psychiatry and emerging sciences, and we touched on a need to be able to understand pathophysiological mechanisms, neuroimaging, new treatments, nanotechnology, stem cell, gene therapy, and so on, and psychological mechanisms. But what we concluded, and what I have said a number of times when I've been talking about training the psychiatrists of the future, is that the therapeutic alliance between the psychiatrist and the patient will remain absolutely key. And going back to Mark's description of not sitting in the room, but wishing he was sitting in the room with his patient who he saw early on in the pandemic. Developments in policy mean that developing focuses on things like prevention, leadership across systems, developing skills to implement change and quality improvement, interprofessional training, having skills of political influence and advocacy for our patients, being able to understand and use digital data and platforms, focusing on collaborative, patient-centered care, so working together with patients on solutions, blurring and possibly erasure of previous boundaries between care systems, possibly between primary and secondary care, and managing limited resources we predicted were going to be key. Being able to care plan, use outcome measures, use of population data, leadership roles, being able to manage the interface with primary care, having a good understanding and commitment to physical health care, and working and supervising new and emerging roles such as physicians, associates, and peer support workers. I've also talked about, when I've predicted and thought about the future of psychiatric training, about policy developments. So many of you will be aware of the GMC's mandate to all medical royal colleges or postgraduate specialties to rewrite their curriculum in line with their document generic professional capabilities, which basically came about from realizing that people who get into trouble with the GMC often have themes in common to do with communication skills and leadership and so on. And these domains that the GMC have developed cut across all postgraduate curricula. So it's gratifying to know that communication skills and so on are just as important in whatever branch of medicine you're doing. And we should be really celebrating that. So as you know, at the moment, all our curricula, our core curricula and our 6 higher specialist curricula have been rewritten and submitted to the GMC. So that's all very well, and that was kind of what I would have been probably talking about in a lot more detail had I been asked to do this talk a year or more ago. But then history happens, events happen, and in response to a journalist's question about what could potentially derail his government, then Prime Minister Harold Macmillan is famously reputed to have replied, "Events, dear boy, events." So I thought what would be useful to do is to reflect together on our experiences so far of the pandemic. And again, lessons from history. Here we are, picture of Zhou Enlai, the Chinese leader, who was asked in discussion with Henry Kissinger, I think in 1972, about what he thought the influence of the French Revolution, which had occurred 200 earlier, was. And he famously replied, "It's too early to tell." Well, it's certainly too early to tell what the implications of a COVID-19 pandemic are going to be. Interestingly, this story is kind of controversial because something got lost in translation. And although he was deemed to be erudite, and this was a very profound comment that he was thought to have made at the time, it was held up as an example of the difference between Eastern politics and a long-term view and short-term Western democratic political thinking. In actual fact, what he was referring to was the French Parisian student riots of 1968. However, whatever way you look at it, he was still saying that 4 years on from an event, it was too early to tell. So I thought I'd just talk a little bit about reflection, because I know that there are quite a few trainees in the audience. And reflection, you know, is sort of can be done to death. It's one of those curses of, or it feels like at times, of modern medical education. But it is absolutely fundamental to our well-being, to our career development, and fundamentally is all about learning. It's only about learning. It's being able to look at situations, to think thoughtfully and carefully about them, and learn as a result. This is the one definition of reflection, and I suppose today we're all here as psychiatrists thinking about our professional practice. We're here to try and learn insight, gain insight, and use lessons learned to make us better psychiatrists. And what I'd like to start off by talking about is about Carol Dweck and theories of social entity. So Carol Dweck was a social psychologist, and I bring this to you because I wish somebody had told me about it a long time ago. Mark was talking earlier about the importance of feeling uncomfortable and learning from that. And Carol Dweck, who's done prolific research in the field over a number of decades, discovered through her research, hypothesized that learners divided basically into two groups of people. Those who were what she called entity theorists and those who she called incremental theorists. And she hypothesized that we all develop deep-seated beliefs about our ability to solve problems, and that leads to differences in motivation, choices, and behaviors. Entity theorists, she hypothesized, believe that intelligence is fixed. And when she looked at small preschool and primary school age children, she described that entity theorists prioritized looking smart. They disliked challenge, they disliked complexity, they found it very difficult to cope with setbacks when they met challenge. And given the choice of an exam or a project task, they would take the exam every time because that defined whether they knew the right answers or not. And so the entity theorists were just as intelligent as the incremental theorists. There was no difference in that. And she gave one of her experiments, both groups, simple maths problems that would be achievable in general by that age group of people. And then she went on progressively to give them harder and harder maths challenges. So, there would be no expectation that, a 7-year-old, for example, would be able to do maths problems which were pitched at the average 10-year-old. And the entity theorists, when they came up against harder and harder challenges, which they struggled to do, had a very helpless response. They denigrated their intelligence. They had plunging expectations. They developed negative emotions. They demonstrated lower persistence. They wanted to give up and decrease performance in the face of anxiety provoking challenge. They saw themselves as having failed. Incremental theorists, on the other hand, believed that everybody with effort and guidance could increase their intellectual abilities. They remained focused on achieving mastery in spite of the present difficulties, and setbacks led to improved performance on the initial easy tasks, in contrast to the entity theorists. So when they went back to the beginning, and these groups had both been challenged by progressively more difficult problem sets, and they went back to do the stuff, the easier stuff, which they'd done well on initially, the incremental theorists performed better, whereas the entity theorists' performance actually decreased. And this was a North American group, so I apologize for it sounds very North American. These kids were saying things like mistakes are our friends. So the key findings from her research over time was that belief about self-influences or our belief about ourselves influence choices in learning activities. And there's a nice example of a Hong Kong study where two groups, both for whom English was not their first language, the entity theorists were more likely to turn down help of additional support with that than the incremental theorists. Entity theorists, as I've said, tend to be focused on a fear of failure, whereas incremental theorists welcome opportunities for growth. And as I said, both perform equally well until they hit failure. So that means that entity theorists are educationally vulnerable. They're educationally vulnerable to changes of setting, for example, from transition from high school to university, and so on. And I would add to that, although there hasn't been any research that I can find on change of environment in terms of country and so on. Our beliefs about intelligence are hypothesized to develop very early on in life. And it's interesting because the instinctive thing that we do as trainers and as parents in praising success, she argues actually promotes entity theory of intelligence, so that our self-esteem becomes linked very powerfully to performance. Entity theory drives competition. We can't all be winners in life. And interestingly, girls are more likely to be entity theorists. That gives them an initial educational advantage, but longer term vulnerability. The important thing to me as dean and as a trainer is that entity theorists are more likely to stereotype others. So we not only give up on ourselves when we hit challenge, but we also give up on others. But there's some good news and a bit of research, a bit of evidence that our beliefs, whilst being relatively stable, can be changed, at least in the medium term. And stereo threat can reduce when students are given teaching on incremental theory of intelligence. And it can also influence younger children's self-perception and performance too. So I wanted to share that with you. And when I've reflected on my own life, I know that I am a fairly hardwired entity theorist when I look back at my education and the competitive environment in which I was educated, as many of us were. And I've had to work very hard over time to move myself into the incremental camp. When I became dean, and I share this with you really as a sort of source of encouragement to those of you in the audience who, if you're anything like me, will look at people standing up or sitting down on Zoom talking and thinking, well, they're different from me, how can I ever be there? I'd say medicine is a conveyor belt, and some of us are just further along that conveyor belt than others. But when I became dean, I'd been encouraged to do that. I had absolutely no ambition. I never saw that as a likely possibility. But I was encouraged by people who saw something in myself that I suspect I didn't see myself. And I stood and I was elected. And very rapidly, I had to make a decision about how I was going to conduct myself. One option was to make an absolute idiot of myself and flight into anxiety state. The other option was to accept that being out of my comfort zone was very rapidly going to have to become my new comfort zone. And I have spent the last 5 years completely feeling out of my comfort zone most of the time, but boy, have I grown as a result and learned skills that I never imagined were going to be possible within my lifetime. So I'd encourage everybody to have a go. So I suppose Winston Churchill, I suspect, knew something about incremental theory, even although the concept hadn't been coined, but that success, he famously said, was not final. Failure is not fatal, but it's the courage to continue that counts. And boy, do we need that at the moment. So I just thought I'd say a little bit on our reflections on our learning about the pandemic to date and how this might influence future developments and influence some of the things that I've talked about earlier in this talk. So some themes, I think, for us to consider, and again, health warning, I don't have the answers, and I don't believe that anybody does. But I think one of the themes that I've thought a lot about is the very rapidly emerging tension of patient-centered care versus population health needs. We are seeing the impact of overwhelming population health needs. We're seeing restriction of all of our freedoms and rationing of resources and healthcare. And that very much came to light very recently with the decision to abandon the protocol with the Pfizer-BioNTech COVID vaccination, 2 doses, 3 weeks apart, and to move on to share it more widely in the population between 12 weeks between the first and second dose, so that it was more fairly distributed. And I think up until date, I have been very privileged in my career when thinking ethically about issues to be able to focus most of the time strongly on patients' autonomy. That's been the driving thing. We think about beneficence, doing good, and non-maleficence, not doing or doing no harm. But we don't, many of us don't have to think very hard working within the NHS about the ethical principle of justice and ensuring fairness. And it caused me a great deal of soul searching, I have to say. I would have been lucky enough to have the first dose of the vaccine. I'd consented on the basis of having a second dose. 3 weeks later, I'd consented on the basis of what I understood the evidence to be, and I'd signed a form. And all of a sudden, I was hearing on the news that that was no longer going to happen. And I have to say, as a patient and as a person, I felt to a small degree violated by that. And I think, again, I was disappointed that we were not having a debate about that. That was nowhere. The GMC weren't saying anything. The colleges weren't saying anything. And people pragmatically and probably rightly were going along with the government view. But I think, going back to some of Mark's points, we do need to be able to speak up and speak loudly when ethical principles certainly need to be talked about and thought about. And I think we're going to have an ongoing tension for a long time. We've come a long, long way in psychiatry in developing concepts of patient-centered care, although we've still got a long way to go in delivering that. But I would hate for us to see the clock turn backwards. The physical health aspects of the pandemic. Well, that's another theme that Mark's already talked about and touched on a lot. So during the pandemic, we've had to make a very necessary contribution to managing physical health care needs of unwell and vulnerable populations. And I hope and I suspect that there will be no going back. I know colleagues who've put in intravenous drips for the first time in many years, who have learned to don and doff PPE, who have cared for people with COVID-19 on inpatient units. The previous very artificial divide is thankfully being blurred. I'm undergoing training tomorrow to be able to give a COVID-19 vaccine in nursing homes. Who knew? Who would have predicted that? Mark's talked already about the neuropsychiatric sequelae of COVID-19, our new disease that we're constantly discovering new facts about. We've talked, I think Frank mentioned long COVID before. And I think we need to think very carefully about what the implications of what could be seen as advances are for us for the future and for our specialty. Connecting digitally. We've all had to embrace technology to enable remote working. We've developed better systems for remotely accessing e-records, teleconferencing, digital apps and platforms for telepsychiatry. And there are likely to be implications for patient choice in the future as how they want to connect with us. When I look back to what I was doing a year ago and having rows of people sitting in waiting rooms waiting to see me, it just feels frankly bizarre that we ever thought that that was a good idea. Now my patients can contact me, remotely. My trainee had somebody contacted them in the window that we had of increased freedoms from a beach in Greece. Patient choice in this is going to be important for the future. We've developed some skills, but we've developed them at pace training. We haven't really drilled down on what the key factors of successful consultation skills are remotely, and we need to do some work on developing that and training. And finally, we need to invest in decent NHS IT support. Somebody who's probably, I reckoned yesterday, I'd probably spent about 30 hours over the last year on calls and trips to IT with various issues about bits of software not talking to each other, and sat in a rotting Nissen hut at the wrong end of a hospital estate yesterday, trying to sort out my Teams and the Siva Care app, accessing my microphone yet again. We really do need to improve how we support our staff with backroom IT support. Stripping away bureaucracy. I think this is a sort of, something I wish for. I've seen little bits of it. It was very gratifying, wasn't it, to have the Secretary of State for Health, I think on last week, when questioned on Radio 4, saying actually we do need to look at training requirements for vaccinators, and knowing that was happening at a governmental level. Some of our systems on non-essential training, etc., have got completely out of hand, and quite why prevent training should get in the way and prevent people coming back to work from retirement to give vaccinations is beyond me. We've seen quite a lot of stripping away of bureaucracy. The GMC have supported the idea of a appraisal light, a lightweight appraisal which focuses on well-being during the pandemic, although in practice I think that has been very patchy at the way it's been rolled out. We've seen, we've been allowed to have derogations from the Gold Guide for postgraduate training, and we've been told that non-essential training, audits and so on are suspended in this wave of the pandemic. Sustainability. Normally, had I been coming to join your education afternoon, it would have involved 4 hours 2 ways on a train, possibly an overnight stay. And similarly for all of our study leave, we were all jetting around the place, and that is unlikely to come back, I think, full force in the future. But I suspect the first person to advertise a face-to-face conference is likely to be inundated by applications, because we all miss the connectedness, the coffee queues, the networking that used to go on, and that this kind of platform makes so difficult. Quality improvement in rapid innovation that we've all seen. We've all got multiple examples of positive change at pace when we've been asked, what is essential? What are the bits that we need to keep going? What are the bits that we can, suspend? What are the bits that, were frankly unhelpful? And I think we've all been involved in reflective learning about what worked and what didn't work. And I know that if East London is anything like Plymouth and the rest of the country, that we're all doing things differently in this wave than we did the first time round. Well-being, and I come back to this, we're all facing challenge from the pandemic in every aspect of each of our lives. There is nobody who's not fighting hard battles at the moment. And I think we've all learned, there's been rich learning about the importance of connectedness, about what makes us tick. We've had time to reflect on priorities in life and reflect on our own resilience. We've seen and we've read about the importance of compassionate leadership in supporting all of our well-being in the front line in NHS. And thanks to Professor Greenberg and colleagues, we know a lot about the risks from moral injury that frontline working in the pandemic can cause, and the importance of developing a pragmatic approach of supporting staff. I think it's really interesting thinking about the impact of trauma on all of us, and the recommendation that that we take a pretty simple, basic approach to going back to basics, to making sure that people are eating, that they're being able to have a good night's sleep, and that they go forward from traumatic situations with the expectancy that over time things will get better. And I do think that we have had some successes in the pandemic in terms of highlighting the importance of mental health, but sometimes that the messages are getting lost in translation, and I do worry about many of the headlines within the media about tsunamis of mental health and so on, because as a race, as a human race, we are resilient, and we will come through this, and the majority of people will grow as a result, but there will be casualties along the way, and we need to be prepared with our services to meet that need. Mark's also touched on recruitment, and I am fascinated to see what will happen to recruitment within the NHS. We've had all sorts of interesting societal developments. We've had NHS workers hailed as heroes. We've had clap for carers and key workers. We are now pretty much accepting of the fact that scientists are cool. Who got a Chris Whitty mug for Christmas with "next slide please" on it, which were trending and one of the popular Christmas gifts, apparently. Who would have thought that that would have been possible? The current focus on mental health in the media may influence our status in the future. And as I've said, some of that media exposure may be helpful, but some of it may also be unhelpful. Parity of esteem, a term I hate, but it's one that we use and everybody understands. There have been some wins in terms of, I think, us accepting our responsibilities as a profession and skilling up. But I do worry about the impact of COVID on waiting times, the missed opportunities for early intervention in physical health conditions, and the impact of that on people presenting late with cancers and so on. And those factors are likely to eclipse mental health need and funding, I believe, for some time to come. So we're going to have to continue to bang the drum and fight hard for our share of funding. Equality, I'm going to just touch on this. It's an issue dear to my heart and part of our key college values in terms of respect. And boy, has the pandemic focused very, very starkly on the impact of inequality on health outcomes. We've seen, certainly during the first part of the pandemic, the NHS leadership being really unrepresentative of the diversity of the people who work in the NHS, and there is much, much work to do, and I really hope that we hang on to that as we go through. Global connectedness, again, there's seldom, well, certainly not in my lifetime, been such a unifying global threat. And that's been able not only to help give a sense of global connectedness in that to an extent we're in this together, but it's also been able to provide us with rich information in terms of differences in our responses, healthcare and social policy and resources. And I would hope that those scientific dialogues would continue over time post-pandemic. So going back to reflection, there are many, many different reflective frameworks written about in the education literature, and no one of them has the answers. Reflection, learning is a very personal choice. You can do it through talking, thinking, talking with others, thinking on your own. You can do it in very creative ways by painting a picture or writing a poem or whatever. And really, I do get a bit fed up with this idea that you have to write a reflective piece to put in your portfolio, which seems to me to be very reductionist. And I tend to think of this fairly pragmatically and fairly simply. And my favourite reflective framework is Wharton's, because you can carry it around in your pocket or at least in your head. So what, so what, and now what? Now what? Well, we've talked about the what and the so what. We know what's happened. We know why it's desperately important. But I challenge all of us to think about what learning from the past, including looking back on Mark's talk, where he talked very nicely about the history of psychiatry, and what learning from the past, from the last 10 months of the pandemic, and from the present, do we want to continue to carry with us into the future? What are the things that COVID has taught us that we want to hold dear? And I just wanted at this point to thank you all for everything that you're doing. Life is terribly challenging at the moment. You are all going over and beyond, every trainee, every medical student, every consultant, every SAS doctor, every retired psychiatrist that might be sitting in your audience at this afternoon are really helping us get through this together. And I wanted to go back to think about what we do as psychiatrists. And I'm going to show you, and I'm not going to apologise for this, but I just thought we'd take a few minutes to reflect on our job as psychiatrists. And I'm going to show you the second of our Choose Psychiatry videos. We were given some money by the military to include a military strand, and I think that feels quite relevant at the moment. So if we just take a few minutes to watch this, and then I will conclude with my final slide.
After I returned, I thought it was over. It wasn't. The battle in my head was just beginning. The truth got worse. I started doing
So finally, I wanted to leave you with a quote from somebody who I hold with a lot of respect, Dame Steve Shirley. She's somebody who has known suffering in her life. She escaped from Nazi Germany on kinder transport. She went on to be an unusual in the 1960s in developing her own, what would now be called a startup computer tech company, and its CEO. She had a son with profound autism who died prematurely in his 30s and had her own personal history of depression. And she says in her book, which I highly recommend, "I know that nothing lasts forever. I know that tomorrow may well be different from today. All the more reason then to welcome the uncertainties of the future and to see each unknown tomorrow as an opportunity, not a threat. We waste too much time being afraid when what we should really fear is wasting time." So thank you very much indeed for inviting me and for listening.
Thank you so much, Kate. I mean, you mentioned earlier the restrictions and the limitations of this kind of presentation, and so you're obviously missing the applause from the audience right now. We shall soon sort of get that back in order. I think it was a very rich and thoughtful presentation, and I personally didn't realize when we planned the event how very well the two talks from you, the two perspectives from you and Mark actually flow together, and how you both essentially relate the topic of COVID to very personal experiences and agendas. And it seems to be one of the common threats of the pandemic, that it forces us to be personal. It forces us to really present ourselves as private people again. And that's kind of also my question, because when I listen to Mark's notion of, well, one of the things as psychiatrists we are good at is to embrace uncertainty, and then the various quotes you also had in your presentation. Is there a case for us to reconsider the curriculum in that respect? I mean, you did put an early slide on in terms of the basic generic skills, therapeutic alliance, and the way we relate to people. I do think, being responsible for medical education, our trust, for example, that there's not enough space for those kind of skills.
Absolutely. I mean, if I was giving a talk to medical students about psychiatry and the skills needed of a psychiatrist, I'd be showing a slide which shows very clearly that the ability to tolerate uncertainty is so important. And I would absolutely echo Mark's point about the importance of supervision and having those discussions, because, you know, it's interesting, isn't it? I was sort of reflecting on, you know, why is everybody so interested in me talking about the future? You know, what do I know? I don't know anything. I can't predict the future. None of us possibly can. Why are we so interested in the future? And I suspect that a degree of that is about dealing with our own anxiety. I think a lot of it is sort of, you know, altruistic, that people want to be able to influence and shape the future and want to predict sort of, you know, patterns and so on. But I think a degree of it is about containing our own anxiety. And, you know, we of all the specialties in medicine, you know, deal with huge uncertainties, off the scale compared, I think, to other specialties. So yeah, it's an absolutely key part of what we do and what we teach and what we learn about.
We have a question from Dave Bailey, a consultant psychiatrist colleague, this is probably one of the now what questions in the chat box. COVID has highlighted inequalities in society and the impact that it has on health and well-being. Given the tension you describe between patient-centered care and population health needs, what do you think the college should be doing to support psychiatrists to respond to Marmot's suggestion that we should be all involved in addressing the social determinants? Yeah.
So I think there's how can the college be involved? Well, at many levels. So, thinking specifically about strategy and ensuring that, and it is in strategy. Adrian James, our current president, has appointed 2 presidential leads for race equality. So from a sort of a policy point of view, I think that it's there in strategy. From an educational point of view, there is stuff. I think people will be very pleased to see our new curriculum when they're published, because there is a strong emphasis within the new curriculum about understanding health inequality, and the stuff in there about advocacy. And one of the things I've been very keen to do in my time as Dean is to be supporting trainees develop influencing skills. So one of the things that I've been keen on, we developed a scheme of parliamentary scholars, for example, who prior to COVID were all spending a year and a day a week with a peer in the House of Lords specifically to develop influencing skills. So I think there's a lot that we are doing, but there is much more that we can be doing. And I think highlighting the importance in publications, in some of the articles that have been carried, for example, in RC Psych Insight. But it's there in front of us, isn't it? We can't ignore it.
I know that a couple of people have raised hands, but we do not really know how to get your questions if you don't put them into the chat box. Probably got time for one more if you want to quickly do so. Lindsay has encouraged us to all read Carol Dweck's work, the book on growth mindset. But other than that, if we don't have anything else coming through here, chat box is disabled, it says. Right, okay. I think we just say thank you again, Kate, and to Mark, if you're still there. A very thoughtful afternoon, I suppose. And I think we got the balance right between acknowledging the fact that we are in difficult times and that we at the same time have to look forward. Yes, there is. And that we, I think it becomes a little bit of a just a hearsay that we can learn from things in terms of extrapolating into the future. But I think this time it is very true, and not only the way we teach and educate in terms of using technologies is going to change, but many things in terms of the way we interpret our roles going forward will actually be challenged, and in a good way, I think, because both presentations have, as I said, highlighted the fact that it reminds us of the core skills, what we bring as psychiatrists to the mix, and that other specialties really don't cover. So thank you very much, and I wish everybody a nice remaining afternoon, and see you soon again. Bye.
Thank you.